This is PowerPoint 2 for RN205, and this is our last video for PowerPoint 2. And we were on infectious diseases. So the last one is conjunctivitis, also called pink eye. Newborns can get an infection of the eye as they're born, passing through the birth canal, especially if there's an STI, chlamydia, gonorrhea, herpes, and it's not always an infection, though. An infant often just gets a blocked tear duct, which will make a little bit of drainage on the eye, and that we treat with just massaging it and warm compresses. So we do need to figure out who really has an infection and who it's a blocked tear duct. In children, it can be bacterial, viral, allergic, or foreign body can make the eye weepy. Most of the time kids, though, even if it's just an allergy in the eye or it's a piece of dust, a piece of sand, whatever in there, they rub it with their dirty, grubby little hands, so it often turns bacterial because they add the bacteria even if it didn't start that way. So with kids, we usually treat it with antibiotic eye drops because if it wasn't bacterial, it will be soon. And the real sign of a bacterial conjunctivitis is those kids who wake up in the morning with the eye just goopy, and often overnight it lets it dry, so then they can't open their eye in the morning until you moisten it and clean off those secretions. And here's a really typical picture. The thick, goopy drainage. Moving on to GU, our biggest most common problem is UTIs. So what causes a UTI? Urinary stasis. The most biggest contributing factor is urinary stasis. So on our potty-trained children, we need to teach them, do not hold your urine. Go as soon as you need to go. Other things that put children at risk, well, girls are at risk because their urethra is so short. It doesn't take long for germs on the surface to get in to the bladder. Boys who are uncircumcised have a higher risk of UTI, infant males. Now, circumcision is still kind of treated as a up to the parents thing because the risk of complications from the circumcision is pretty much equal to the increased risk of a UTI from being not circumcised. So it's really kind of a wash, and we just tell parents it's their choice. Vesicoureteral reflex. This is the valve that from the ureter into the bladder doesn't shut right. So when the bladder constricts to push out the urine, it pushes some back up the ureter, and then after you're done going, that urine that had gone retrograde up the ureter comes back into the bladder. So now we have urinary stasis even after you just went. Constipation, it makes compression of the urethra, so you end up having difficulty going or retaining urine in there. Poor fluid intake, that urine's just going to be more concentrated and including more bacteria. Bubble baths, these are a big issue with little girls particularly. Again, there's very little distance from the skin into the bladder, and so anything that irritates the skin, bubble baths, soaps, lotions, they just shouldn't be used in the private areas of little girls. Little girls wiping from back to front, right? Taking those germs from the rectum up to the urethra to the meatus. And then tight pants also contribute. Moving on to the hematologic system. So what do we have in that? That's our blood cells, right? So we have our red cells, erythrocytes. These are responsible primarily for carrying oxygen. That's their biggest job. Thrombocytes, or also called platelets, they're part of the clotting process. Leukocytes, which are white blood cells, these are responsible for fighting infection. And we often divide leukocytes up into granulocytes and agranulocytes. And those granulocytes are your neutrophils, eosinophils, and basophils. Your agranulocytes are lymphocytes and monocytes. The first and best bacterial fighters you send out in an infection are neutrophils. And usually the first thing you send out in a viral infection are lymphocytes. And if you've ever heard somebody talk about a shift to the left, they're talking about neutrophils that or granulocytes, but usually neutrophils. So that's an indication it's a bacterial infection. And this actually is a neutrophil, and you can tell because of this lumpy multinucleated thing. Moving on to childhood cancers. How is childhood cancer different from adult cancers? Well, the tissues are where kids get cancer rather than in an organ like adults. The most common is in the blood and then the lymph. So blood is leukemia, lymph is Hodgkin's, and then brain, bone, kidney, or muscle. Where adults, the most common is breast, lung, prostate, bowel, and bladder. Environmental factors really don't contribute to childhood cancer, where they strongly influence adult cancers. Detection: childhood cancer usually is just accidental or incidental. You're looking for something else and you find it. Where with adults, we have early detection, mammograms, labs, things to try and catch those cancers, those common cancers early. The good thing is childhood cancers respond well to treatment. Adults, not so much. Adults, it's really about how early you catch it. So our most common childhood cancer is leukemia. This is really a cancer of the bone marrow. What we have is unrestricted proliferation of immature white cells. So tons of white cells, but they're not mature and they don't mature, so they never really work. So there's no actual tumor, but those immature cells, those leukemic cells, will invade organs, usually liver and spleen, and also they'll often go into the central nervous system. So what happens is destruction happens from the infiltration, and then there's competition for metabolic elements. And in the bone marrow, the problem is those cancer cells take over all of the material used for creating cells in the bone marrow to make these immature, non-functioning white cells. So other cells are not made, so they end up low in everything else. And then we treat that by using chemotherapy, which kills off the bone marrow, but if you have no bone marrow, you're not making those cells. So anemia is a big problem. So, well, really all of the cell types. So we do need to give these kids, while they're in treatment, they need to get frequent blood transfusions. And our kids with trisomy 21, which is Down syndrome, they have about a 20-time increased risk for ALL, leukemia. That chemotherapy, oh my gosh, it does kill the cancer cells, but it also makes you nauseous, makes you vomit, kills off all the cells that mature rapidly, which includes the lining of the mouth and the GI system. It makes you bleed easily and anemic because it stops your bone marrow from making stuff. It makes the hair fall out because, again, it's anything that multiplies quickly. So when we're dealing with hematologic issues, I want to separate pallor from cyanosis. What makes you pale and what makes you cyanotic? Well, pallor is from a lack of hemoglobin carrying oxygen because you don't have enough hemoglobin. Cyanosis happens because you have hemoglobin with no oxygen on it. So you have to have desaturated hemoglobin to look blue. If you just don't have enough hemoglobin, you're going to look pale. You're going to have a low hemoglobin hematocrit RBC when you're pale, because that's the problem. You don't have enough of those. Where in cyanosis, you may very well have enough of those, and if it's gone on for any length of time, you're going to actually have high hemoglobin, hematocrit, RBC, you're also going to change the morphology of the RBCs, make them bigger, put more hemoglobin on them to try and compensate. That doesn't happen immediately, but it does over time. So in pallor, your saturation's normal. Every hemoglobin is carrying oxygen, you just don't have enough hemoglobin. In cyanosis, your saturation's low because you have hemoglobin not carrying oxygen. So some of the symptoms, pallor, you just don't have enough oxygen to take out to the tissues, so you're easily fatigued. It usually happens from blood loss or from anemia. And I'd say in anemia, our big culprit on that, if it's not a cancer, it's a toddler who drinks too much milk. Milk is low in iron, and they drink the milk instead of eating food that has iron. So iron deficiency anemia is a toddler problem. For our cyanosis, we have something interfering with gas exchange, right? Because they have the hemoglobin, but the hemoglobin's not picking up oxygen. So this we do want to treat with giving them oxygen. We want to maximize that gas exchange. The exception to that is if it's from a cardiac defect where we're taking deoxygenated blood returning to the body and sending it back to the body. So it does not go to the lungs. It skips the lungs, shunts from the right side of the heart to the left side of the heart. And in that case, oxygen's not really going to do anything because then it's not a gas exchange problem. But most of the time it is. And that's the end.